Hello, fellow colleagues. I trust you're keeping safe and well. My name is Dr. Winfred Mwangi. I'm a consultant anesthesiologist and also a critical care physician. Here on behalf of the Kenya Society of Anesthesiologists, along with the Critical Care Society of Kenya, we aim as a society to look out for the safety in terms of anesthesia and critical care for our fellow Kenyans. I currently work at Nakuru Level 5 Hospital as one of the consultants in anesthesia and critical care. And today I want us to discuss COVID-19 and anesthesia, which we know it's a worldwide pandemic, and how does it affect us when it comes to anesthesia. So the outline of this discussion today will be an introduction, basically on COVID-19 and transmission, which I'm sure we're all familiar with. And then I will define anesthesia for those who may just have a gray area about what it is about. And the types that we have, which basically is two arms where you have regional and general. And then we need to consider certain people, i.e. pediatric populations, obstetric patients, geriatric patients, and patient comorbidities. So these are also special considerations that we have to think about when it comes to discussing anesthesia. And of course, we must look out for the anesthesia. So anesthesia provider wellness is a factor that we're going to look into today. So as we're all aware, COVID-19, which has been with us for over a year now, is caused by SARS-CoV-2 virus. So the pathogen is actually transmitted by inhaling respiratory droplets or exposure to a mucous membranes, hence why you must have a face shield, because exposure to your buccal mucosa, your eyes, actually can lead to transmission of this. And also when you're in close proximity or in relatively closed off environments, which for anesthesia is very crucial because we tend to work in theaters, we tend to work in critical care settings, and this can be very closed off environments. So contamination of surfaces, that's where we're sanitizing everywhere, can also be a source of transmission. Minimal, but it also presents a risk. So airway management, which is where my specialty comes into play, poses one of the highest risks in terms of exposure to COVID-19. So that's why we have SOPs, those are standard operating procedures, and IPC, that is infection prevention control protocols to safeguard healthcare workers. So the goal with COVID-19 prevention, really prevention is key. So anesthesia. So anesthesia is a state of controlled or temporary loss of sensation and awareness induced for medical purposes. So it involves both analgesia, paralysis, amnesia, and unconsciousness. So general anesthesia, that is CNS suppression with injected or inhaled drugs. As we know, you can have injected forms or you can have inhaled forms. And then you have regional anesthesia, where you actually block transmission of nerve impulses to a certain section of the body. So when you're discussing local anesthesia, for instance, this is actually regional anesthesia at play. So due to airway management, anesthesia providers are at very high risk of exposure to COVID-19. So because of that, we actually are preferring to have regional anesthesia as the mode for giving anesthesia for surgery going forward in view of the current pandemic that we're in. And like I said, this is what blocks transmission of nerve impulses to a section of the body. For a C-section, a cesarean section, that would be a subarachnoid block. For amputation of a digit, that would actually just be a nerve block, peripheral nerve block. So depending on what you're trying to achieve, that's what you do for regional anesthesia. So it's a preferred mode of anesthesia currently because it limits exposure to the airway, it limits aerosolization. So by aerosolization, we all know that, I mean, like, you know, when you breathe out or when you're exhaling, so those airway droplets can actually be transmitted from the respiratory system of that patient who's COVID positive out to everyone else in that room. So like I said, you have subarachnoid block, epidurals, peripheral nerve blocks. This is now regional anesthesia. But when you're planning for regional anesthesia, you must always be ready to give general anesthesia. There are times you will try regional and it fails. So you have to be ready to convert to general anesthesia. So let's have a little bit of a chat about general anesthesia. Like I said, it's CNS suppression with injector inhaled drugs. Still includes analgesia, paralysis, amnesia, and unconsciousness. So this involves the management of the airway, which brings about the issue of aerosolization, which is what's going to expose the provider and those around in terms of the COVID-19 virus. And then after, they have manual or mechanical ventilation. So the 2 points that are very critical when you're giving general anesthesia is induction, when you're now intubating the patient, and reversal when you're going to be extubating the patient. You must have a specialized airway specialist or specialist provider, that's an anesthesiologist like myself, with an assistant, at least 2, present when you're about to do general anesthesia. So some of the things to consider that we consider in anesthesia: you must have secure patient transport to and from isolation. We're now discussing a COVID positive patient. You must have a dedicated theater, including the equipment dedicated for COVID-19 patients. Fumigation between cases is crucial. Not all COVID-19 patients are the same. We cannot assume they have the same viral load. Full PPE is mandatory for all team members present. Patient must have the mask on at all times, this is assuming you're doing regional anesthesia. If you do go general anesthesia, you must have HEPA filters between the patient and the circuit to the machine that you're going to use, your anesthesia machine that is. Please use disposables where possible. If not possible, cover with clear plastic, okay? And remember to always sanitize all the time, before, during, after. So preoperatively, remember to always have proper donning and proper doffing with a buddy system, someone who's going to see places you have missed, or someone who's going to also be checking that you have donned properly. So this must be observed. Even when you're doing the pre-anesthetic review, when you're doing your pre-op, please make sure you also don when reviewing this patient. So now with COVID patient, the one thing that we need to consider is there must be some emphasis on the respiratory status of the patient, also the cardiovascular function of the patient, vis-a-vis just your normal pre-op. So these are things that we need to do, especially with post-COVID patients. So you can have a patient who had COVID, recovered from COVID, but due to lung fibrosis, we like actually to make sure we do our respiratory status for the patient. If the surgery is elective, postpone. Unless it must be done, let's try and postpone elective surgeries. Please have a team discussion from the surgeon to the nursing team, to the ward nurses, to the ward doctor, to the anesthesiologist when planning for a surgery. And then plan this as a team effort. Have a dedicated pathway for transport and let those team members be appraised so it's clear to avoid contamination of other members. Post-operatively, post-operatively, you want to reverse a patient on the table. You want to extubate on the table. If the patient is not being reversed and extubated on the table, take the patient to isolation ICU or the negative pressure ICU that you've designated. Once the patient is reversed, we do not have, currently we don't have a dedicated PACU in most places. Patient continue their PACU in the allocated ward, hence why I said it must be a team discussion, okay? Disinfect all the surfaces and equipment at the beginning of the day, between the cases, and at the end of the day. Remember to always double bag, seal, spray medical waste, and discard according to the IPC protocols of your institution. Now here's a biggie for us anesthesiologists, airway management. So remember before, we need to protect ourselves and we must protect the team we're working with. So you must have hand hygiene, you must have full PPE, you must have an isolation room, and the goal is to minimize aerosolization. Remove your watches, badges, tags, everything. Just make sure you have labeled on your head cups or scrub caps to make sure that team members know who's who. Remember also you must have teamwork. It's very crucial, okay? So everything should be prepared before going into the room where you're going to induce. So before the OR, you should have a pre-room where you have everything ready, your drugs, your equipment. You plan the mode of anesthesia ahead of time. You have your plan B, C, D, all the way to Z. Medication is ready. Airway assessment was done at pre-op, so you make sure you have the most conversant airway person ready. Have closed suctioning system tested, ready to go. Ideally, we may not have this in most of our centers in Kenya, but video laryngoscopy is what is recommended. But if not possible, please do your direct laryngoscopy by the most conversant person. So this is now an example of someone who's ready. Everything is ready outside we're ready to go in. You can see he has on the top a myriad of syringes, laryngoscope with blades, and below he has a variety of airway management devices. During, so there must be clear delineation of roles. This is the anesthesiologist who's going to manage the airway. This is a primary assistant. This is a nurse who brought in the patient. So there must be clear delineation of roles. Then there must be closed loop communication. Hi, my name is Dr. Winnie, I'll be intubating. Yes, Dr. Winnie, you're intubating. So it must be closed loop communication. Clear communication of airway plan should have happened before and it continues inside. Cross monitoring of each other. Remember, we're only as good as our weakest link. So you must look out for each other in case of potential contamination. So there are the technical aspects which I've already discussed, but just to put emphasis, airway management must be by the most experienced practitioner. And let's use the lowest gas flows to maintain oxygenation. COVID patients do not tend to have a lot of reserve. They tend to actually desaturate faster than expected. Also have a tight-fitting mask with a two-hand grip, okay, to minimize leak. That's why you must always have assistants, at least one or two. RSI, this is rapid sequence induction and intubation. This prevents bagging, which is going to risk and promote the potential of aerosolization. Ensure paralysis of the cords. So when you're intubating, the patient doesn't cough, which is also an aerosolizing procedure. Decreased apnea time actually happens with COVID patients. So we're trying to avoid severe hypoxemia. So let's do RSI and have the most experienced practitioner present. Positive pressure ventilation should only be done after you've intubated and inflated the cuff for the endotracheal tube. Now, after you're done, let's avoid unnecessary circuit disconnection. If you must disconnect, you might consider clamping the tube, yes or no, but you must always be ready with full PPE and have a standby ventilator if possible. Remember buddy system when you're doffing, okay? That person has to look out for you and you look out for them. Hand hygiene is a must, and a team debrief. COVID-19 is a pandemic that really is taking all of us by storm. So we must team debrief before and actually pre-brief before, okay? So these are the special mentions I talked about earlier. So the pediatric population actually would recommend some pre-medication. This reduces crying and also generalization, and also avoid nasal administration of any drugs. And to be honest, if we pre-medicate nicely, we are trying to actually avoid parental presence at induction because they tend to be less willing. The preferred method of induction is intravenous, obviously, if it's possible. But we find that with most of our babies, you cannot do intravenous induction. So still do RSI. Make sure you have adequate muscular blockade to allow your intubation, to facilitate your intubation. If you must do your mask induction, remember again, lowest possible flows and have a clear plastic barrier between you and the patient's airway. This will reduce your risk of contamination from aerosolization of the patient's airway. Obstetric patients. So obstetric population is actually very special because you actually have two lives in one. Labor analgesia is recommended, very recommended, and should be performed by the most experienced provider, okay? So people are trying to avoid having nitrous oxide as part of labor analgesia and opioids as well because of the respiratory factors and also because you want the oxygen levels to be high. Let's aim to target our SpO2s 95% and above. If there's a need for supplemental oxygen, please early warning scores for escalation of care must be present and assessed constantly, all right? We aim to minimize intrapartum breakthrough pain, so we'll use higher doses when giving labor analgesia, and region is still preferred for cesarean section vis-a-vis having general anesthesia, but aim to have very good hemodynamic control intraoperatively, all right? So the same contraindications that we have for epidural blood patches due to post-dural puncture headache, they still apply. So now for us healthcare providers, remember what I said, pre-briefing and debriefing. We're constantly exposing ourselves and it's a team effort. So let's look out for each other. Let's make sure everyone is safe. Let's make sure everyone is mentally okay, physically okay. Please do limit your encounters with patients without compromising the care of the patient, okay? We're here for the patient at the end of the day, but let's not have constant interactions if it can be helped. If you have been exposed, one, there must be protocols in your institution to healthcare workers who have been exposed. If not, KMA can help you initiate some and make sure that is in present. Have a test done, okay? A primary test. Go for isolation for at least 14 days from your last encounter with the patient. And then you retest according to institutional protocols. For Nakuru, we retest within the first 8 days, and then 10 days, and then 14 days. So depending according to your institution, please do retest. If you do get any symptoms, please report your symptoms. There are checklists out there like Sahat, which is an app that you can download where you can actually check to see how you're feeling. Where indicated, you can do your C-reactive proteins or HRCT, your CT scan where indicated, but otherwise, you should be good to go and your institution to give you these protocols. And I cannot overemphasize counseling of all members of any team when it comes to looking after COVID patients, especially with anesthesia where it's a lot of aerosol generalizing procedure. It's not a short case, you're exposed to the patient constantly. So counseling for all members, pre, intra, post debriefing is very crucial. And then at the end of that, you have a happy patient, you have a happy team, and always safe anesthesia. So let me quickly just go through some questions that we frequently get as anesthesiologists. Yes, I know surgeons are eager, and OB-GYNs are eager to know how soon can we resume electives. So for instance, in my institution, we have resumed some electives. There's some electives which really cannot wait. There are what we call cold emergencies, and then what we call, dire emergencies. And so when do we decide to go in or not to go in? So it all comes back to the team discussion. For instance, a 2 previous car cannot wait forever, all right? She's a patient who's going to need a surgery at some point in time, so we plan. However, probably someone who needs liposuction can wait for a little bit longer. So it's actually up to the team effort to discuss and decide, do we need to go in and what we need to prepare for? Because this elective surgeries, you need to make sure you're prepared before you go in, so you're prepared for anything that might happen eventually once you're in. Now we're finally here with the COVID vaccine. So operatively, what do we consider? The same factors still come into play for anesthesia when we're doing preoperative checks for a patient that we would do for any other patient and that we would do for a COVID patient as well. So the same preoperative measures are necessary and should be taken, investigations and radiology to be factored in. Now, regional versus general anesthesia, I cannot overemphasize this. Regional anesthesia is the way to go. But if you must, we must always be ready for general anesthesia. Some of the things to factor in is COVID-19 is going to very quickly become a comorbid condition that we've had before because it causes lung fibrosis. It also has been shown to cause high incidences or discovery of diabetic or pre-diabetic patients. You have your hypertensive patients. So all the factors you consider with comorbid patients, it is necessary to actually factor them in when you would prefer to use regional vis-a-vis general anesthesia. The one thing also I wanted to share is pain management. Please, let's make sure adequately we manage pain for our patients. It's one of the key things that brings patients to hospital. So let's adequately manage pain. And if in any doubt, please do consult your nearest anesthesia provider. Please do find us KSA and CCSK. And we shall be happy to work with you. Thank you so much.